Thank you very much for the opportunity to present. It's a bit strange recording this separately to a presentation, but here it goes. So many of you will know this slide from Jurassic Park, where Jeff Goldblum's character questioned the scientists. So sometimes this is what I feel we end up with in medicine. Obviously, the caveats to this talk are I'm a geriatrician and has this associated biases. I also hope that not everyone agrees with everything I say, because sometimes that conflict is where we learn the most and has the most opportunity to change. So these are just 3 recent clinical scenarios that I had in my practice. I don't think any of these patients are unusual or have any conditions that many of you don't deal with either at the same time. So hospitalization, older people are heavier users of the hospital system versus younger people. So unless you practice pediatric or adolescent medicine, about half of your patients will be older. So my view is that we can either keep putting our collective heads in the sand, or that we can start to look at how we improve care for older people. The top 3 emergency surgical procedures in Australia, hip fracture is still one of the most common conditions, and this is almost entirely a condition of older people. What's unusual about the Australian setting is that a lot of elective surgery, about 60%, is done in the private setting, whereas the vast majority of emergency surgery is done in the public setting. And much of the biggest increase in surgeries in people who probably 10 years ago wouldn't have access to surgery, which is the oldest old. It's about a 10% annual year-on-year growth in rates of elective surgery in this group. And things like cataracts are really important to improve quality of care on these people. Hip replacements, assuming the patient group is well selected, again, can have huge improvements in quality of life. But the flip side to this is that in some areas, older people are less likely to receive treatment than their younger counterparts. And when the Royal College of Surgeons looked at this in the UK, the conditions they were looking at were breast, colorectal cancer, gallstones, and osteoarthritis of the knee. Again, common conditions in older people. Some geographical areas had almost no procedures in the older age. So then we have 2 sides to the same issue. One is inappropriate lack of access to people who require it and are likely to benefit. And the flip side is inappropriate over-servicing of people who are unlikely to benefit. So decisions regarding surgery in older people, I think that there's kind of 4 key ways of thinking about this. And I quite liked how the College of Surgeons in the UK put these forward. So the first we're going to talk about are clinical factors. So within clinical factors, we have patient factors and we have surgery-specific factors. I'm not going to spend any time really talking about surgical-specific factors, but I think it's really important that we consider the location surgery has been undertaken and whether day hospitals for people, for example, with significant cognitive impairment are the best place to look after these patients. So when we go in then to the patient factors, so multimorbidity is a term that us physicians are using much more than comorbidity. It's really where there's 2 or more comorbidities that are present at the same time and both carry equal weight. And I think this is the case for many of the patients we see. The literature suggests that that's about 3 out of 4 older surgical patients will have 2 or more chronic conditions. The American study showing a much lower rate of chronic conditions is probably because they looked for candidate comorbidity. So they specifically looked for comorbidity that was associated with increased risk. So I think that the 36% actually greatly underestimates the relative comorbidity. And then if we look to David Story's paper, which is quite a few years ago, you can see that it was actually quite common for people to have 2 or more conditions. In fact, about 1/3 of the study population had that. And it was much more prevalent in the non-survivors. And again, population data supports this. And obviously, if you have multimorbidity, then you're going to have the other follow-on things such as polypharmacy. So again, coming back to David Story's work, comorbidity, and you can see here that those with 3 or more comorbidities were much more likely to have died than those with 0 comorbidities. And again, this is just descriptive data rather than any inference data. Jonathan Hewitt's work looked at the association between multimorbidity, age, and frailty, and it was on consecutively admitted patients 65 and older admitted to an acute surgical unit in the UK, and really didn't find a lot of association between multimorbidity and all of those factors. Whereas this Spanish paper, if you read on the surface, it looks like mortality is twice as prevalent in those with multimorbidity, but when they adjusted for age, sex, cancer stage, and treatment, this association didn't hold up. So to me, I find, like, what are some of the challenges about multimorbidity? So how do you separate out multimorbidity from frailty, polypharmacy, or complexity? And then how do we classify in terms of treatment strategies? Is the patient with type 2 diabetes, ischemic heart disease, and COPD more important than the person with COPD, depression, and chronic kidney disease? And then how do we interpret single trials, like single condition clinical trials, into the context of someone with multimorbidity, and how should that inform the care we provide? I don't think we have any of those. So moving from multimorbidity to geriatric risk factors. So the main 2 that I'm going to speak about today are frailty and cognitive impairment, and I'm just mindful of not spending too much time on either of these. So when I talk about frailty, I'm describing vulnerability and health status of a person compared to others of the same chronological age. And really, you're comparing either 90-year-olds with another 90-year-old or the same person across 2 time periods. And there's a very clear linear relationship between age and frailty. So anyone who's read any perioperative medicine paper recently would know there's 2 schools of thought around frailty. Linda Free describes "you know it when you see it," which is actually very in keeping with what the lay person would describe as frailty. And then Mitnitsky and Rockwood looked at that more mathematical model, or conceptually as a multidimensional risk state. And this here is the clinical frailty scale, which is one of the most commonly used frailty measurement tools around, and it's a highly validated tool which has been studied across multiple different scenarios, both in hospital and in the community, and medical and surgical patients. So if we look at some of the data around prevalence of frailty, it looks like a lot of older people, especially those admitted from the acute surgical unit, are quite frail. But again, what this doesn't tell you is when they considered the person's functional status to be. So for example, were they looking at people how they were on admission, or were they looking at people how they were 2 weeks pre-op? And that just have to take some of the studies with a grain of salt in that sense. There's also the impact of frailty after surgery. So any of us would sit up here in this yellow line where we trot along, we're independent, then we have operation, there's a small drop in our function, but we quickly recover. Older people, they're much more likely to be hovering just above that line of independence. They drop down to become dependent after an operation, and then it takes them much longer to recover. And this here is currently why the person's still in hospital. They can't get out of bed of their own accord. They can't get on and off the toilet. They can't make themselves a cup of tea. And if they live alone or with another spouse who's old and not in good health, this really can significantly impact their length of stay, but also their discharge destination. So what can change outcome in frail people? Well, unfortunately, there's actually not a great evidence base. A lot of the perioperative literature seems to have spent its time talking about association studies rather than studies to change outcome. But I think there are some clear things that we can do. We should look to see whether we're providing appropriate versus futile care, and shared decision making is really important in this group of patients to make sure that the care that we're delivering is in alignment with their expected outcome and with their values. So moving from frailty to cognitive impairment. So again, Australian data suggests that dementia prevalence increases markedly after about the age of 80. And depending on what tool you use, about a quarter to a third of people have cognitive impairment if you actively go screening for it. I think this rate of cognitive impairment in this colorectal surgical group is probably a bit high because they used a very high cutoff of the Montreal Cognitive Assessment Score. And some of these studies here also use neuropsychological assessment, which most of us would not use in regular clinical practice. So if we look at the emergency surgical group, obviously the rates of cognitive impairment look much higher, but I would suggest that what a lot of these studies were actually capturing was intercurrent delirium. And the Montreal Cognitive Assessment Scale is not really good for diagnosing delirium. What I will draw to your attention to is this vascular group, in which 2/3 of people had an abnormal Montreal Cognitive Assessment Score. About 9 out of 10 of those patients were not known to have any pre-morbid cognitive impairment. So cognitive impairment is probably more prevalent than we think it is. It means that people are more likely to develop delirium, and many of them are not known to have cognitive impairment unless we go looking. And this is relevant for the following issues. One, rates of delirium. We talk about risk of infection and wound breakdown and cardiac events, but actually if you've got pre-existing cognitive impairment, your rate of delirium is much higher. It also indicates that there may be other geriatric risk factors present. And I think the things that we haven't thought as much about or talked about is capacity to consent to planned treatment, advanced care planning, and then, for example, how is an older person with cognitive impairment and poor eyesight going to manage a stoma if the planned operation is actually something like a Hartmann's procedure or an ileostomy? So then moving from into more clinical decision making. I like to think about decision making. We all come into these things with biases, and that's completely normal. And I think the main thing about biases is to know when they're present rather than try and get rid of them. And I see this as an opportunity to support or refute a decision. So why do we offer surgery to older people? Well, life extension or quality of life are by far the two main reasons. In fact, probably the only two reasons. Obviously, the decision is impacted whether it's elective surgery or emergency surgery, and then even within the decision to offer surgery, there are choices within that procedure. So in the majority of cases, surgery does prolong life, where that's the primary goal of care. But the things that we need to think about is where is that person in terms of their life expectancy? What is their chronological age? Because no matter how much people like not to think about it, it is very important. So if you look at these papers from the US, so these are obviously 3 different surgical groups and looking at nursing home residents in the US. And in the US, there's the minimum data set that can be accessed for nursing home residents. So in all of these studies, the 1-year mortality rate was 40 to 50%. That's probably less to do with the operation, but more to do with the likely life expectancy of people in nursing homes. So you really wonder, in someone with colon, incidentally diagnosed colon cancer who's in a nursing home, is that person going to die from the colon cancer? Because it's different if they're nearly obstructing from it versus if they just have a small malignant polyp that's found on routine screening. So each of these bits of information is important into the decision around surgery or not. And then if you look at what's naturally the functional outcomes of people in nursing homes, generally most people, their function declines over time. The reason that someone's in a nursing home is for either physical or cognitive reasons or both. They're no longer able to look after themselves, run a household. Most of the time they need help with showering, dressing, getting on and off the toilet, and managing medications, etc. So when we look at then survival in the emergency group, so if you've got a community dwelling group of older people, emergency laparotomy is obviously one of the highest risk procedures. If we add frailty into that, that's an additive to risk. So emergency surgery is much more likely to be associated with mortality than elective surgery, and I think this. But then, if most of us think it seems reasonable that there's more older people dying after surgery than younger people, and I would certainly agree. But I suppose, do we get the outcomes that we expect? Do we give older people the same level of intervention as younger people? So, for example, the QUASM study that Jenny Allen and co-wrote, when they looked at those over 80, they had decreased rates of unplanned return to theatre, unplanned intensive care admissions, treatment in intensive care versus younger people. And there's obviously that UK report which reported on structural and cultural issues and how older people were treated. And so if we're talking about surgical treatment that saves lives, what happens if we do nothing? Well, that's actually been really, really less defined. Certainly for hip fractures, and the Australian hip fracture registry shows that about 96% of people with hip fracture are operated on in Australia and New Zealand. And there's a UK group which are now looking at the mortality in the emergency laparotomy group, or in those that don't undergo emergency laparotomy. And I think this is going to be very interesting. So if we've said surgery is about saving lives, then how about improving quality of life? A lot of the surgical literature, functional status is spoken about the same as quality of life, and certainly the two are very important, but from a research perspective, quality of life and function are not quite the same thing. So in most of these studies, about 20% of people had no improvement in their quality of life after surgery. Interestingly, those with colorectal cancer were more likely to report improved quality of life versus either of the other operations, which probably talks more about psychological relief of distress. And those that undergo emergency surgery rather than elective surgery, the evidence suggests that they are much more likely to have poor quality of life outcomes than those who have elective surgery. And I suppose that, again, stands to reason. Emergency surgery is rarely around quality of life, but more around that life prolongation. And if we ask older people what they want from surgery, independence is generally what someone would say is their most important priority. But many of our patients suffer an optimism bias, and their expectations of what surgery can offer them are unrealistic. And I certainly, in my clinical practice, find it really interesting to ask people, what do they expect, for example, their joint replacement is going to offer? And what you find out is that they think it will really unwind the clock 4 to 5 years, and that can be a really useful point for at least helping them revise down some of those unrealistic expectations. We also know that the functional status that you start at really will determine your recovery trajectory and whether you will get that functional improvement. So Thomas Gill's group here selected 4 pre-morbid functional status, so you either had no disability, mild, moderate, or severe. And they looked at basic activities of daily living, which is bathing, dressing, walking, instrumental activities such as shopping, housework, meal prep, and then mobility activities such as walking a quarter of a mile or climbing a flight of stairs. And then they tracked recovery after surgery. And you can see here that those that started off without any disability, most of them had either a rapid or a gradual improvement in symptoms. Whereas if you look at the group over here with severe disability to start with, it's actually very common that most of them had at most a partial improvement, and the vast majority had little to no improvement in their function. So I think this is a really, really important thing when you see someone coming in who's been bedbound and thinks, for example, that a joint replacement will help them get walking again. It actually may not. And so taking into account why the person has this level of disability and where they are in terms of their life expectancy is really important. Again, Paul Miles's group looking at validating the HUDAS. And again, you can see that disability-free survival at 6 months is actually quite poor. And interestingly, the orthopedic group, you can see here, they thought it was a hip fracture. But when they took out the knee or hip arthroplasty, the disability-free survival was even lower. So moving from So I use the shared decision-making process that I like to use is BRAN, which is benefits, risks, alternatives to surgery, and what happens if we do nothing. And this is often an interesting group of questions to ask patients. I always like to talk about what happens if it all goes pear-shaped. And it's quite interesting how many people have never thought that this is something that could happen, even if they're having really quite major surgery. So that shared decision making around finding out their expectations and setting goals and expectations that are relevant to the surgery the person's having and their quality of life currently and their functional status. And I think sometimes that we expect a lot of surgeons. So I think that it's important we look at sharing the burden with like-minded colleagues. So for example, having an anesthetic colleague or a physician colleague who you can speak to for additional advice if you're not sure whether surgery is still the right thing. And I think that there's a role for this collaboration. I think it strengthens our shared decision-making process, but it also supports the patient. So then how do we better select older people? So I think we need to know what we don't know. So we need to think about geriatric risk factors like frailty and cognitive impairment. But we found when we did a project at Logan that about 4 or 5 people had a risk factor, which we didn't quite expect. And the vast majority of these was polypharmacy. So these are the questions that I think are worth at least scooting through your mind when seeing an older person, especially coming from major surgery. And some of these, will be relevant in some people and not all, but it at least provides a kind of a start, especially when you kind of get that gut feeling that maybe it's not going to be quite as good as. So then finally, we've got pathway-related factors. So I think most of our preoperative pathways are now showing their age. They talk about anesthetic risk when our anesthetists now are so good that very, very few people die in surgery. And it's actually the complex discharge planning is the major issue. I also think that when issues are identified, no one really knows what to do with the result. And then when someone has a date for surgery, everybody is invested in it. And so it's really, really hard to change things. And I think that we label our patients incorrectly. We see them as bed blockers when actually we have failed to plan appropriately. So how do we change this? Well, identifying the right people is important. I think emergency surgical group have been traditionally a very, very neglected group, and I think it's time to start changing that. So what's the role of comprehensive geriatric assessment? So basically, it's a multidimensional, multidisciplinary assessment and management plan. It's delivered by a team. And in the perioperative setting, I would see that the surgeons and anaesthetists, as well as the nursing and allied health team, will be an important part of this. So for the emergency laparotomy group, if you see a geriatrician post-operatively, you have a 60 to 65% reduction in 30-day mortality. And there's also improved outcomes in emergency general surgery and vascular surgery. And it's the team that's got the most evidence rather than just the specialist alone. If we look at it in the elective setting, comprehensive geriatric assessment preoperatively in vascular patients reduced length of stay by 2 days, reduced delirium by about 50%, and decreased medical complications. And this is an example of a recent comprehensive geriatric assessment from my clinic. You can see here that there's plans for medical management, for geriatric risk factor management, for social issues, and then inpatient management. So in summary, I think perioperative care of older people does require service redesign. I think we all have a role to play in it, and I think that future care models are likely to see